Hello and welcome to tonight's SCI Forum. My name is Jeannie Hoffman and I'm a clinical psychologist in the Department of Rehabilitation Medicine and the director of the Northwest Regional Spinal Cord Injury System here at the University of Washington. Tonight I'm so pleased to welcome my colleague, Dr. Kate Delaney, who's an acting assistant professor in the Department of Rehabilitation Medicine and an expert in spinal cord injury. And she's going to be discussing bowel care after spinal cord injury and going through different options to figure out a bowel program that works for you. So, Dr. Delaney, turn it over to you.
All right. Thank you, Jeannie. It's great to kind of see all of you all tonight and know that you're here. So I'm excited to talk about this topic. We'll be talking about bowel management after spinal cord injury. And as Jeannie mentioned, I'm one of the spinal cord injury physicians. I have clinic here at University of Washington Medical Center. I also do inpatient rehab at Harborview Medical Center, so it's possible I may have run into some of you in those contexts or for some of our SCI programming. So I don't have any disclosures tonight. And tonight we'll go through a few things. First, we'll talk a little bit about typical bowel anatomy and function. Then we'll talk specifically about what happens with bowel function after spinal cord injury. We'll talk through some options for management and then talk through some complications related to bowel care, as well as options for how to manage maybe difficult bowel programs. So the first thing to think through, as I'm sure many of you know, is that the spinal cord injury itself provides the nervous system input to basically all of the organs in the body. So in addition to the muscles that move limbs, arms, and legs, this provides nervous system input to the bowels themselves and to the functioning of the body to actually have a bowel movement. So first we'll talk through how that works in general. So if we're thinking about the digestive system, what happens is somebody, eats or drinks, and that goes in through the mouth, travels down through the esophagus, and ends up in the stomach. From there, those particles move into the small intestine, which on this picture are a lighter pink color, kind of in the middle of the abdomen. After that, they travel to the large intestine, then to the rectum and to the anus, and that's where those products are expelled as stool. This is a little bit of a closer view of the large bowel, as many of the interventions we have or options are actually affecting the large intestine and its function. So while the food products are in the small intestine, the body is working to absorb nutrients and digest that food and works with assistance from the other organs such as the pancreas or the liver to provide enzymes to break down food products. In the large intestine, there is some absorption of electrolytes and water from that stool product. And then the large intestine's job is also to just move the stool along and keep the stool stored until it's ready to be evacuated. And during that process, it's working on adjusting the water content of the stool so that it continues to move forward and is able to exit the body. So as you can see in this picture, on the left-hand side, there's what's called the ascending colon that's labeled in green, and that's because it travels upward. Then there's the transverse colon, which means going straight across. So that's traveling from the right side of your body to the left side of your body, and then the descending colon, which travels down the left side of the body into the rectum, and then finally the anus before stool leaves the body. In the bowels themselves, there's a complex system of muscles and nerves that are lining the bowels and the intestines that help propel stool along. There are also some reflexes that naturally occur in the body that help move stool along. So essentially, as things are moving through the intestines, it triggers the body to keep it moving. So a few of these reflexes, which I'll refer to later on during the presentation, and which you might have also heard of, are the gastrocolic reflex that kind of translates to the stomach-colon reflex. So essentially, when somebody has something to eat or drink, that gives the body a signal to keep the stool moving along in the colon. So if there's something in the stomach, then that gives a signal to keep stool moving on in the colon. There's the colocolonic reflex, which kind of translates to colon-colon activity. So as stool is moving along and kind of causing the colon to expand, then that gives itself a signal to squeeze the muscles and keep things moving. And then finally, there's the rectocolic reflex, which means rectum to colon reflex. And that's referring to when the rectum itself is stretched. And similarly, that gives some feedback to the colon to move the stool along. So I mentioned kind of the nerve input to these muscles that line the intestines or the bowel. And there are a couple of kind of categories of nervous system input to the bowel. So there's the parasympathetic system and the sympathetic system. The reason I'm mentioning this is because these signals originate from different parts of the spinal cord. And so this is one of the reasons why people with different levels of spinal cord injury might have a different impact on their bowel function. So the parasympathetic input, generally speaking, works to increase gut motility, meaning to continue to allow things to move along through the gut. This uses input from the vagus nerve as well as the sacral spinal cord, so some of those very lowest segments of the spinal cord. The sympathetic system works on sphincter activity, so it helps contract the sphincters, and it, generally speaking, decreases gut motility. And this has nervous system input from the thoracic spinal cord and the lumbar spinal cord. This is a closer view of that bottom part, kind of the rectum leading into the anus, right before stool leaves the body. And there are a couple of important sphincters in that area. So there's the internal anal sphincter as well as the external anal sphincter. And the internal anal sphincter is just a little bit farther inside of the body than the external anal sphincter. The internal sphincter, we have involuntary control over that. What that means is that's not something we're aware of and controlling, but it rests in kind of a shut position. And one of the main things that does is help prevent any accidents or incontinence. The external anal sphincter is the one that people may have voluntary control over. So that's something that if somebody has a sensation to go to the bathroom, they have control either to hold it shut to prevent any accidents or incontinence, or to use that to help stimulate the stool exiting the body. And what happens as the stool moves through the colon and the rectum is it uses some of the reflex activity that's naturally a part of the body's function to relax that internal anal sphincter to allow for it to open up and the stool to exit the body for a bowel movement. And I already mentioned the rectocolic reflex, which means that when the stool is in the rectum, or if something else is stimulating the rectum, this also encourages the stool to be pushed along in the colon and to exit the body. And finally, abdominal muscles can be used to help push out the stool just by increasing the pressure inside the abdomen, which helps move things along as well. So that was a summary of what happens with typical bowel function, some of the nervous system input and where it comes from as things are moving along, mostly in the large intestine, because as I mentioned, that's where things might turn out to have some problems after spinal cord injury, or where some of the medications or other things that we use have effect. So after spinal cord injury, there are, generally speaking, two patterns of bowel dysfunction that might happen. One is called reflexic bowel. Other terms for this include spastic bowel or upper motor neuron bowel. And that typically happens for people who have injuries above the level of T12. Then there's areflexic bowel, which is also sometimes called flaccid bowel or lower motor neuron bowel. And that happens when people have injuries below the level of T12. Sometimes there can be a little bit of a mixed picture for people whose injuries are kind of on that border zone. And one main thing to know is that for reflexic bowel, or for people who might have cervical or thoracic spinal cord injuries, the internal anal sphincter kind of stays closed at rest. And so there's a lower risk of incontinence if the stool isn't already moving along. For areflexic bowel, or those lower injuries, which might be in the lumbar spine or the sacral spine, or including cauda equina syndrome or sometimes conus medullaris syndrome, the internal anal sphincter at rest is open and it's on the looser side. And so that leads to a little bit of a higher risk of accidents or incontinence if there are not other factors of the stool that might be better controlled. Another thing to keep in mind is that kind of for any level of spinal cord injury, in addition to the motor function that's affected, sensation might be impaired. And so individuals with spinal cord injury might not be able to sense fullness in their rectum to give a signal of when it's appropriate to go to the bathroom. And sometimes for people with incomplete injuries, this clear separation between reflexic bowel or areflexic bowel might not be so clear because they may keep some of the reflexes that other people might not have if they have a lower level injury. Another thing to keep in mind is that after spinal cord injury, generally speaking, the gut moves things along a little bit slower. So individuals with tetraplegia have slowed stomach emptying, and so the food from the stomach takes a little bit longer to move on to the small intestine. And then kind of anybody with spinal cord injury, but with higher injury, things tend to move slower. There is a slower transit throughout the intestines overall. So it might actually take as long as 2 to 4 times as long for things to move from the stomach all the way through the intestines and out of the body. And so for people with spinal cord injury, bowel management is often a main focus of the medical care that we provide. And the reason for this is because it can be a big factor that affects quality of life. And so on survey studies, a large number of people, between 25 to 60%, depending on the study, report that they're limited by bowel problems, meaning that they're not able to participate in life in the way that they hope to because of issues with bowels. Most of the time, this is reported to be a problem with the time that it takes to do the bowel program or with accidents or incontinence. The goal is to use what's called a bowel program to help regulate the bowels. And the hope is with a bowel program that the bowels can be a little bit more predictable, that individuals can evacuate the bowels fully, which will help reduce the risk of an accident later on. Things that go into the bowel program include potentially changes to diet, to medications, and there are considerations that should be made about what type of equipment or assistance people might need. And ideally, the bowel program is done in a seated position because gravity can help move things along. If that's challenging, then it is also, if people do it in bed, to do it in a side-lying position is best. The goal for a bowel program is for it to take less than 1 hour. And ultimately, the hope is that with this regular type of program, people will not have incontinence or accidents. That's one of the main goals. And the system is different for the bowel program depending on whether somebody has a reflexic bowel or a higher injury or a reflexic bowel. So we'll talk through some of the options or strategies for each of those types of bowel dysfunction. So for reflexic bowel, as I mentioned, this typically includes individuals with cervical injuries or thoracic injuries. This may include medications and some other options. So starting with medications that we might consider could involve stool softeners, stimulants, suppository, which is also called a contact irritant, or fiber. Although something to know is that this might cause constipation if people don't have enough water intake, and I'll get into that a little bit more. For somebody who has a reflexic bowel, the goal is to do a daily or every other day bowel program, or sometimes people may do it 3 times a week. And that typically involves eating a short time before the program to try and use what's called the gastrocolic reflex, or that stomach colon reflex, to use the suppository to stimulate the other reflex, rectocolic reflex. What that does is when there's something irritating the rectum, it gives a signal to kind of move things along and push them out. And then using digital stimulation to help evacuate the stool that's down in the rectal vault. And that can be done every 5 to 15 minutes. And the goal is to have soft form stool that can exit easily. For people who have areflexic bowel, which tends to be individuals with lumbar or sacral spinal cord injury and can include cauda equina or conus medullaris. Some medications also are effective, including stimulants like senna, bulking agents like psyllium or fiber, and water. Something that's interesting is there actually are no clear guidelines on what the right ratio is of water to fiber intake. And we can provide kind of general recommendations, but that often needs to be titrated to the individual. And the goal with areflexic bowel is to have a daily or twice a day bowel program, which involves manual removal of stool from the rectum. And the hope is that the stool is firm, formed stool. And some things that might help move that along is using abdominal massage, activity or standing, and to do the bowel program while seated. And something to note is that for a lot of people with this type of injury and this type of bowel, a suppository or digital stimulation might not work because they don't have the reflex activity that the suppository is supposed to take advantage of. For somebody who has a very incomplete injury, that might not be the case. And so there are some things on physical exam that we can check to try and help figure out what's going to be the best strategy. But those options might not be that good for somebody who has an areflexic bowel. So this is a chart of a lot of the medications that can be used for bowel management. And the specifics of this, can often depend on the individual. But generally speaking, there are some medicines that are stool softeners, such as docusate, stimulants like senna or metoclopramide, which is also called Reglan, contact irritants like bisacodyl, and laxatives like milk of magnesia, magnesium citrate, lactulose, and Miralax or polyethylene glycol. They all work in a little bit of a different way. And so some of these medications help propel the stool along, and some of them affect the consistency of the stool. And so that's why it might be helpful to be on certain types of medications or to change medication or add something if you're looking either to improve the timing or to improve the consistency of the stool. Something to note is that there are several different types of suppositories as well as mini enemas. And the coating that's around the suppository itself can make a difference for how well it works. So there's a specific suppository called Magic Bullet, and that actually tends to result in a faster bowel program than using a bisacodyl suppository alone. Similarly, a mini enema can actually lead to a faster bowel program as well. So those two things might be options if the bowel program is taking a long time for people who have a reflexic bowel. Something to think about for the timing of senna, which is a stimulant that a lot of people use, it's over-the-counter medication, is that it tends to take effect about 8 to 12 hours after it's given. And so it's useful to take this medication not at the time of the bowel program, but either in the evening if you do it in the morning, or in the morning or midday if you do an evening bowel program. Something to know about medications or any change in medication with the bowel program is that it can take several days to notice the effect of any change that you make. So often it's recommended only to do a change once every 3 to 5 days. And so a lot of times right after an injury, or if things are changing over time and we're trying to optimize the bowel program, it can take some time to figure out, because any change that's made might take up to a week to notice the full effect and to see if it's actually effective or not. So earlier I was mentioning fiber intake, and like I said, there actually aren't any great studies that tell us specific guidelines for how much fiber or water to take in, but the general recommendation is to have at least 15 grams of fiber daily for people with spinal cord injury. So for the general population, the recommendations are to have between 20 to 30 or 35 grams daily. But for people with spinal cord injury, because the stool moves along more slowly, there's a risk with fiber that it can cause constipation. Because what fiber does is it acts as a binding agent to help with the consistency of stool. And people need to have enough fluid intake, around 40 to 60 ounces of fluid daily, to keep up with that amount of fiber to make sure that constipation doesn't happen. What I would say is that some people really have a good effect from fiber and it helps. Other people, if they take it, it tends to cause constipation, and sometimes it's a little bit of a trial and error. Here are some pictures of things that have high fiber in them that you can add to your diet. It includes berries, in particular raspberries, pear, apple, green beans, broccoli, grains like barley, wheat, or rice, and beans. There's also fiber supplementation, but these are foods to consider incorporating into your regular diet, which help with maintaining that fiber intake. And for the bowel program itself, we talked a bit about some of the medications or diet changes that can impact the bowel program, but something else to consider is kind of the best strategy to use for people with different levels of injury or different function based on their spinal cord injury. So we often think about what type of equipment is best based on an individual's trunk stability, their hand or arm function, their transfer skills or need for assistance, and if they have any difficulty with clothing management. In general terms, although this isn't 100% perfect, what we anticipate is that for somebody who has a level of injury C5 or higher, that they are likely going to need assistance to do the bowel program. For people who have an injury that's C6 or 7 level, they might be able to be independent with the bowel program, or they might need assistance, depending on some other factors for their health and just how well they're able to take advantage of some of that additional arm function. And for people who have an injury that's C8 or lower, oftentimes they can be independent, but again, for this group, there are some things that impact how easy that is or not, like arthritis, body size, range of motion of the spine, or shoulder problems. These are all things that either right away after spinal cord injury or as time go on might make it difficult to do a bowel program independently. It might be worth checking in with your doctor, occupational therapist, to think through some strategies to make it easier if those things are becoming a problem. And this is a table that describes some of the specific types of equipment that are useful for people with spinal cord injuries of different levels. What I would say is that for each person, they really need an individualized evaluation, and that often includes with occupational therapy, maybe with your physician or rehab nurse, to think through kind of different strategies to be as independent as possible and what equipment is going to work best. So I've included some pictures of, for example, a rolling shower commode chair, which can help with allowing people to have an upright position while doing their bowel program instead of doing it in bed. That can help move things along. In the middle, there's a picture of a suppository inserter, as well as a piece of equipment that can do digital stimulation. What I would say about that is sometimes for people who don't have sensation around their anus or on their buttocks, that type of equipment may or may not be useful because sometimes it can cause skin problems or skin breakdown, and this is an area that is at high risk of infection if there's skin breakdown. So those are options, but have to be considered in a little bit more detail. And then finally, a transfer board or a slide board, thinking about the big picture of where's the best place to do the bowel program. Is it possible to do it in an upright position, which often can help. So now I'm going to talk through some options for that could be helpful if somebody has a bowel program that's a little bit difficult to manage. There are some newer medications that are available. These first two that I've listed, linaclotide or Linzess or plecanatide, those are medications that increase the fluid influx into the colon. They work as stool softeners as well as stimulants. There are no studies in spinal cord injury using these medications. Sometimes they're worth trying if people have used all of the other medications that have been tried in spinal cord injury, but we don't have a lot of great information about how much they would help or not. Prucalopride is a newer medication that's approved in the US, I believe in 2019, and it's been used in Europe for about a decade. That increases peristalsis, meaning kind of the movement throughout the colon of the stool, and so it's a stimulant. There are a few studies in spinal cord injury that do show that it can be helpful, but not as many as with some of the other medications we use more commonly. Finally, there's a couple of medications that can be used in particular for individuals that take opioid medications, like naloxone or methyl naltrexone. So for somebody who has a spinal cord injury and neurogenic bowel from that, and take some pain medications that also contribute to constipation, then these might be options to add if they really are struggling with constipation. For all of the things listed on this slide, it might require a separate GI evaluation. Sometimes they do extra tests and they trial the medications at different doses if they might be options. Another thing that could be considered is using transanal irrigation. There's a device called Peristeen, which can be used to help insert water into the rectum itself, and that basically works to flush out the rectum. So this has been studied in people with spinal cord injury who both have reflexic or areflexic bowel, so basically any level of spinal cord injury. And it can help in particular for people who have a prolonged bowel program or have difficulty with incontinence or accidents or problems with having a regular bowel program. There are some serious but pretty rare risks of having a bowel perforation or a hole in the bowel. More commonly, what happens is that it might not work well, and so the individual stops using it. In the studies they've done in spinal cord injury, it has been effective for around 65% of people, and so it really could be something to consider. A problem that we run into is that it is fairly expensive. It's not covered by Medicare, which is a big problem for a lot of people with spinal cord injury, as that's a common type of insurance. It is often covered by commercial insurance or private insurance, and I don't know that I have personally had it approved for somebody who has Washington State Medicaid, but might be approved in that case. So there are a couple of pictures I've included. So on the left, this is the setup. There's kind of a bag which holds water and tubing that connects to a pump that can be squeezed either by the person themselves or by an assistant if somebody has difficulty with hand function. There's a catheter, or kind of that end of the tube, that can be inserted into the anus and into the rectum, and then you pump up a balloon that helps hold it in place. And then finally, you use that pump to insert a certain amount of water into the rectum, and then release the balloon, which allows everything, the water in the stool, to exit the body into the commode or the toilet directly. So things to consider is that if somebody does have other medical conditions that affect the colon, like diverticulitis, diverticulosis, inflammatory bowel disease, this device is not safe to use in those cases because that really increases the risk of bowel perforation. So I've included the list of things that you would need to think through or discuss with your doctor for reasons that it might not be an option, but it might be something to consider in a fair number of people. So if it seems like this might be useful, and it might be useful, for example, if other medications have been tried and aren't effective, we've tried to change a suppository, mini enema, or evaluated technique for digital stimulation, none of those things have worked, then you can speak with your doctor about it, who can basically apply on your behalf to try to use the device. And then we do trials in clinic where we have nursing, maybe an occupational therapist if we're thinking about the best equipment or way to use this device, as well as an evaluation by the physician to do a rectal exam to make sure it seems safe, to get an x-ray of the abdomen, and to figure out the best settings for the balloon and the amount of water used. So there are also some stimulation devices that are not very well studied for people with spinal cord injury, but for each of these there have been maybe one or a few observational studies. When I say an observational study, what I mean is that they've looked at how this device has worked for people who have already decided to get it. They haven't had a group that tries the new device, or an experimental group and a control group to see is it really more effective or not. And so we don't consider this the best type of evidence to decide if something's going to work well or not. But there's a little bit of information that we know for how it works for spinal cord injury. So a few options include sacral anterior root stimulation. What happens there is there are electrodes that are placed on the nerve roots in the sacral spine, and somebody has an implantable device that's placed in the abdomen. The picture on the right is for the second one that I'll talk about in a second, but for this one, the device is placed in the abdomen, similar to where like a baclofen pump would be placed if you have that or have seen somebody with that. That device can be used to stimulate the nerves, which stimulate a bowel movement. So this could be considered for somebody who has really severe constipation. And in these couple of studies that are not the best type of study, the people have found that they have more frequent bowel movements, so helps with constipation and also for reduced time for bowel program. This option does require a surgery, which takes out some of the bone, as well as surgery to the nerves themselves. So it is riskier than some of the other options. Another newer device is a sacral nerve stimulator, and it's a similar idea where they put an electrode on one of the sacral nerve roots. The device itself is placed in the buttocks, and so that's what this picture is of. You can see the device that's kind of put right over those pelvic bones, and this has improved incontinence or accidents and reduced constipations in those couple of studies where they included people with spinal cord injury. Similarly, that does require a surgery to put in. It's not as invasive of a surgery as the sacral anterior nerve root stimulation, but it is an invasive procedure. And then finally, there's posterior tibial nerve stimulation. And that just had one observational study for incomplete spinal cord injury. And it was shown in that study to reduce incontinence or accidents. That involves stimulating the nerve actually in the leg to try to change the signals that are occurring up closer to the spinal cord. This can also be done for bladder issues and is used more commonly in people with spinal cord injury for that reason. The benefit is it isn't a surgery, it's not as invasive, but we just don't know a lot of information about it. Like I said, there is this one small study and only for people with incomplete spinal cord injury. And I should mention that for the second option, the sacral nerve stimulation, that only looked at people with incomplete spinal cord injury as well. So I would say these might be things that ultimately end up being beneficial, but we don't currently have a lot of great information about how well they'll work for people with spinal cord injury. Another option that does involve surgery is what's called a Malone anterograde continence enema, often referred to as a MACE. That uses somebody's appendix to create a stoma or a hole in the abdominal wall, where you can see here there's a syringe that's filled with water that can be inserted into that hole and help flush out the large intestine. The goal is that the stool still comes out through the anus, but the hope is that when this is timed in the right way, that it helps with improving regularity of bowel program, and in studies that has been shown to improve quality of life and having a more regular bowel movement. But similar to those other devices I was just talking about, there are no high quality studies in adults with spinal cord injury, so it's something that we don't know a whole lot about. Finally, this is an option that's used much more often in adults with spinal cord injury and has been better studied, which is considering a colostomy. And what that is taking part of the bowel, large intestine, the colon, and attaching it to the abdominal wall, and then putting a bag over it, as you can see in the picture on the right, and that bag collects the stool. And so a colostomy for people with spinal cord injury can be helpful if the bowel program takes too long, if people have incontinence or accidents, chronic constipation, or a lot of wounds that are worsened by bowel incontinence. Most individuals who choose this do report that they have an improved quality of life, and the studies have shown that people have fewer hospitalizations, that their independence is improved, and they have to spend less time on their bowel care. Things to consider kind of around the time of getting this surgery, as well as moving forward, is that there is a period of time, which is usually 6 weeks, where people can't do the same level of activity they usually do in order to allow the site to heal. So that often takes a bit of planning in terms of if people need additional assistance at home. We also sometimes think about if new equipment would be needed, or generally new assistance is needed because somebody would be doing the bowel program in a different way than usual. So now I'll talk through some complications that we see for people who have neurogenic bowel because of spinal cord injury. So definitely the most common one is constipation. That's pretty common in people who have spinal cord injury. What that refers to is when somebody has hard stools, they have a small amount of output with their bowel program. The bowel program takes a long time, or they're having less frequent bowel movements. For somebody who has sensation in their abdomen, they might also have abdominal pain or nausea that goes along with that. One thing I'd like to point out is that if somebody is still having some stool, but it's only liquid, that sometimes can be because there's a lot of hard stool that is blocking the way, and it's only the liquid that's able to seep out around it and exit the body. So if the consistency of your stool has changed a lot and it's only liquid, this actually might mean that you're constipated instead of having diarrhea, and it might take an x-ray to figure out what really is going on. This is a picture of somebody whose abdomen is what we call FOS, or full of stool, or another word if you want to think of it that way, where you can see kind of this cloudy looking appearance all throughout the abdomen, and that is just poop in there. So this person is quite constipated. On the right side, you can see some kind of darker areas, and that's where there's some gas buildup as well. So ways to help manage constipation or to increase fluid intake, to think about reviewing medications, both bowel medications as well as other medications that are commonly used in people with spinal cord injury that can cause constipation, like pain medications, baclofen, and anticholinergics, which can be often used for bladder spasms. To think about activity, try to increase time sitting, standing, using a standing frame, or generally in an upright position. Consider using much stronger medications to effectively clean out the bowels as best as possible, and then restart the goal bowel program medications. So this chart here shows a bunch of different pictures of stool and you can see that these top two, where it's very hard or just kind of small pellets coming out, that indicates that there's constipation or pretty significant constipation going on. Generally speaking, for people with spinal cord injury, the goal is to have a type 4 stool. So that's kind of smooth and soft, easy to exit the body. Maybe a type 3 or 4 for somebody who has a reflexic bowel, where you're trying to have the stool come out but not cause any accidents because of the low tone of the sphincter. Another common complication is hemorrhoids. And this is often, what hemorrhoids are kind of inflammation and enlargement of the blood vessels very close to the anus. So this is a picture of them. You can see kind of that angry purple looking thing. They're both internal and external hemorrhoids. And for people who have sensation, you can feel external hemorrhoids. They might be painful or itchy. For internal hemorrhoids, they're often in the area of the body that nobody has sensation, so you may not know they're there. You just notice that there's blood in the stool. So this can often be caused because of constipation. So often the first step is to think about softening the stools, because any increased pressure can predispose people to developing hemorrhoids. Also think about the technique for digital stimulation, and if that might be irritating the tissue in that area, or if it needs to be changed temporarily because of the presence of hemorrhoids. There are also topical medications that can be used both to help with symptoms of hemorrhoids and to try to shrink them. If somebody is having a lot of bleeding or really other significant problems such as severe autonomic dysreflexia, and it's thought to be related to hemorrhoids, it's possible that banding or surgery could be an option. But those have pretty high rates of the hemorrhoids coming back. And so it's not usually the first step to go to, but might be an option if other things have been tried and they're just not helping. Finally, I wanted to mention something that is also fairly common with people with higher level spinal cord injury is getting autonomic dysreflexia during the bowel program. And there are a few things that can help with this. Often we start by trying to change the stool consistency, have it be a little bit softer, because constipation or hard stool can be painful, which can trigger AD. People can also try different types of topical medications, like using lidocaine gel for digital stimulation itself. And there are some mini enemas which have a numbing medicine, kind of a cousin of lidocaine, called benzocaine. Like Enemies Plus has this in it, which can help reduce the risk of AD because it numbs the area. If this is kind of coming up suddenly, then it's important to check for any new skin issues or other things that could be going on, including if there are hemorrhoids, and specifically those internal hemorrhoids that people may not be aware of otherwise or can't see as easily. And if we've tried everything and it's not getting better, then a lot of times, because obviously people need to continue to regularly empty their bowels, if this is really consistently causing dysreflexia, then we might use medications to treat the AD itself, like using medicines for to reduce the blood pressure directly, or using pain medications to try to tone down that pain signal that might be behind the AD, so that people's blood pressure doesn't get too high. And I should have mentioned, this might be a concept that a lot of people are familiar with, but in case that's not the case, autonomic dysreflexia is kind of a reflex activity that happens in people with spinal cord injury of a higher level, typically higher in the chest or in the cervical spine, where if there's something going on below their level of injury that they don't feel but might cause pain in the body, that causes a reaction in the body to have a high blood pressure, sometimes flushing or sweating. And we worry if the blood pressure gets too high when these events are happening. Similarly, if somebody does have really persistent AD during the bowel program and it's hard to manage, then we might consider one of those other options to manage the bowels, like using an anal irrigation device like Peristeen or a colostomy. The tricky thing there is that one of the things that, not a direct contraindication, but something we have to consider for Peristeen is AD it can cause AD. So it's often something that we kind of have to trial in clinic and see if it's helping or making it worse. Similarly, a colostomy, it's a surgery that sometimes can cause things to temporarily get worse before they get better. And finally, I wanted to just talk through a couple of things regarding general health for bowels, colon, intestines. For people with spinal cord injury, there's not any increased risk of colon cancer compared to the general population. And so the recommendations are the same, meaning the guidance is to get a colonoscopy once every 10 years, a flexible sigmoidoscopy once every 5 years, or to do a fecal occult blood test each year. The tricky things for each of these is that for the fecal occult blood test, which is basically taking a sample of stool to see if there's any blood in it, often that has a false positive for people with spinal cord injury if they do digital stimulation or use a suppository, because they're having more injury to that tissue than people who don't have a spinal cord injury. For the flexible sigmoidoscopy and a colonoscopy, often people need to do bowel prep ahead of time. On the next slide, I'll talk about that in more detail. And just wanted to bring it up here because the guidance actually recently changed, where the age of starting colonoscopy is now recommended to start at 45 instead of 50 years old. And so it's recommended for adults aged 45 to 75. For some people who have a family history of colon cancer, that may in fact start earlier. And something to note is that because it takes longer for the whole, for transit kind of throughout the whole system in the intestines for people with spinal cord injury, a bowel prep for colonoscopy or another reason might take longer. So sometimes it's necessary to do it over a couple of days instead of just one day. And for people who do get a lot of AD or a lot of problems with their blood pressure, low blood pressure, it might in fact be needed to be admitted to the hospital to do this. And so if you have trouble with your bowels or AD and are due for a colonoscopy, then that's certainly something that we might need to coordinate as a team. So just wanted to bring back the outline again. We talked a little bit about typical bowel anatomy and function, how that function might change after a spinal cord injury, and the two broad categories of bowel dysfunction, having a reflexic or areflexic bowel. Some options for management, including medications, diet, activity, doing a bowel program, and some other options if it's difficult to maintain a consistent bowel program, as well as some complications that can come up related to bowel care and spinal cord injury. So at this point, we have some time for questions or conversation, if that would be helpful.
Excellent. Thank you so much. So I have a few questions. We'll start with one that I got early on, which is why is it, I might be mispronouncing this, cecostomy, CECOSTOMY. Yep. Why are those not used more in bowel management? And, maybe you could explain what it is to everyone, and then is it something that people could consider using?
Sure. So I'll bring up this picture again of the mace because that's really the same thing as a cecostomy. So a cecostomy is having a hole or an ostomy that connects to the abdominal wall from the cecum, which is this lower part of where the tube is going in on this picture. So one of the reasons this is not done very often is we don't have a lot of information about it for people with spinal cord injury. So there are more studies on using anal irrigation device as well as a colostomy directly. And so we tend to use those options because we have more information about how well they work or not. I would say that this is maybe a less, in a way, it's maybe a less invasive surgery than a colostomy. It is, however, still a surgery. And so maybe it might also be that if people have already tried all of the other medications and anal irrigation device and are not having any improvement with that, that the colostomy is more likely to be a kind of a more surefire way to get improvement. So I think that it could be an option. It's not done commonly for people with spinal cord injury, and I would say it's not done commonly for adults, generally speaking. So another barrier might be the familiarity of the surgeon themselves with doing this procedure. It's most often done in children who have spina bifida or some other kind of neurologic diagnoses that affect bowel management. And so we just have more information about how it affects that population.
Okay, thank you. So another question is, you mentioned that sometimes pain medications are used to manage autonomic dysreflexia during bowel programs. What class of medications or type of pain medications are you referring to?
Mm-hmm. It can be kind of anything that might help treat pain, from Tylenol to opioid or narcotic medications. The main thing is we often look for medicines that can be taken and have an effect, right away. So when you take a Tylenol or an Advil or a narcotic pain medication, it tends to have an effect fairly quickly and then wear off fairly quickly. So other pain medications like gabapentin, for example, doesn't work in that same way, so it might not be as effective for the bowel program in particular.
At what point should you consult your physician about your bowel program? Like, when do you bring it up? Or is that something that should always be talked about with any kind of annual review or,
Yeah. I would say that if there's a change in bowel function or bowel program that is causing problems, like incontinence, taking a longer time, having a lot of constipation or just variability, definitely a good point to check in with your doctor. This is something that is brought up during a typical annual evaluation for spinal cord injury. But if there are questions or if it's just not working well for you, then it's very reasonable to bring it up sooner.
Somebody mentioned that they read recently that there's limited evidence that stool softeners are actually effective. Are you aware of that, or can you comment on that?
Yeah, so they did, they kind of did, there was a publication specifically about the stool softener Docusate or Colace, where they did this big review and they found that it kind of didn't make a difference. This was for the general population, not specifically for people with spinal cord injury. And so that's actually one reason why it's not offered or it's not available in our hospitals in this system, was because it was not found to have enough evidence behind it to be effective. What I would say is that historically over time, that medication in particular has been used fairly commonly for spinal cord injury bowel program, and some people find it to be really, really helpful. So it's one of those things that might be helpful even if the large body of evidence says it might not work. That's thinking about people typically with different bowel function in the able-bodied population. I'm assuming that's what that person might be referring to. I'm not aware of that being the case for other stool softeners, but that definitely came out maybe
very particular.
Yeah, 5 to 8 years ago or so for Docusate.
I'm not sure that you can answer this necessarily without knowing, more details about the person, but they're saying that they take a Senna tablet once in the morning and once in the evening every day, but they do their bowel program once every 2 days. It seems like it may be the incorrect approach, but
I would say two things. That generally the best way to use Senna is in that time period, 8 to 12 hours before doing the bowel program, because it's a stimulant that helps in that way. If it turns out that this is how it's been used over time and it's working, then I often
don't
say,
mess with a good
thing. It's not necessary to change it if it's not causing a problem. But if
Yeah.
there are problems with being regular or not, that might be something to look more at.
Yeah. So another person asked about like the complexity of hemorrhoids and digital stim.
Yeah.
So digital stim can cause hemorrhoids, but sometimes digital stim is what helps for bowel programs. So kind of what's the, how do you decide?
Yes. Honestly, that is very tough. What I will say is that you can make the digital stim more focused. Basically, generally speaking, the method is to kind of like make a full circle for the stimulation. If there's a hemorrhoid or some other problem in one part of the anus, you can change your technique, and it might not be as strong of a reaction, but it still will be some reaction. So you can just change the area where you do the digital stimulation. And I would say that's the other, taking oral medications to help soften the stool to make it pass more easily, and to think about using topical medications for the hemorrhoids themselves to try and shrink them up are the best ways we have to manage it, but it really is often just a tricky problem. We kind of go back and forth, and there's no great perfect solution.
Yeah. Does bowel motility tend to improve or deteriorate over time with an incomplete spinal cord injury, or is it totally unpredictable like everything else?
Generally speaking, kind of in all people, constipation is more common with aging, and so people with spinal cord injury fit into that as well. So it is the case that over time, over the order of years and decades, somebody's bowels might change. I would say during the period of time that people might have improvement in other ways from an incomplete injury, they can have improvement in their control of bowel function. But if somebody is out of that window, it's many years since their spinal cord injury, I wouldn't anticipate that it would get better or get worse, but it might naturally change with the body as other things do.
Aging, yeah, that. Any special considerations for children with spinal cord injury with difficult bowel programs? Any other suggestions or thoughts? I know you've focused primarily on adults, but of your awareness, do you have any other suggestions?
No, I guess I would say that I do know that in children, similar medications are used. That it's more common to use that procedure where you can flush or irrigate the bowels, called MACE procedure. And oftentimes, Peristeen or anal irrigation device can be used as well. So similar techniques. I'm not aware of other options specifically for that population.
Okay, thanks. What do you think of using plain water enemas?
So I guess it depends a little bit on the situation. In general, it's not great to be using a large volume enema on a very regular basis. Like, that's not a goal to be doing for a bowel program on a daily basis, for example. If it's needed, somebody needs to use it occasionally, then it is okay to use that. Other enemas include medication that have a bit more of an effect. They irritate the tissue in the same way that maybe a suppository does or a mini enema. And they also help pull in even more water, which can help move the stool along. But there isn't anything, if it works, that's not a problem to do it. I would just say it should not be used very regularly, like on a daily basis.
Would acetaminophen be beneficial on a bowel program days for autonomic dysreflexia sweating?
It could be tried.
Yeah.
Yeah.
Something worth considering.
Mm-hmm.
For stool softeners, if they are effective, should they be taken consistently and daily?
A lot of times, yes, but sometimes people end up taking them a couple times a week or every other day. And sometimes once somebody's bowels are pretty well controlled generally, they might only take them as needed if they're noticing that their stool is getting a little bit more hard over time. So I would say that varies, and that might be one of the things that changes. A few months after spinal cord injury might be different than a few years after spinal cord injury in terms of how many medications somebody needs or how often they have to take them.
Somebody's surprised to learn that too much fiber can cause constipation. I always thought that more fiber helped with bowel movements. Can you explain the difference between soluble versus insoluble, and which one should people with spinal cord injury be focused on?
So what I would say about fiber is that if the ratio between the fiber and the water intake is not right, meaning there's more fiber compared to the water, then what that does is it bulks up the stool, brings the stool into one place, but it doesn't make it soft enough to move along. So that is the situation where people can be at risk for constipation, and people with spinal cord injury are at higher risk than the general population. So in a lot of ways, it depends on that balance between the fiber and the water intake. Similar to the question about Senna, if this is something that somebody uses regularly and it's working fine, that's totally fine. It probably means you got the ratio down and that's working well for your body. There are differences in soluble and insoluble fiber. I cannot off the top of my head recall kind of which foods are in which groups, and there's not guidance for spinal cord injury in particular about which ones to focus on. So I would say if there are recommendations for anybody for the breakdown, it would be the same for spinal cord injury. There's no difference between those groups. In the most recent evidence that we have.
So just in general, it tends to be a little bit lower recommendations in terms of fiber compared to the general population.
The total intake is a little bit lower. Yeah.
Okay. Do you have to be worried about the flora in the GI system when you're doing any kind of flushing on a regular basis? Either, I would assume, mace, peristeen.
Right.
Yeah.
Not that I'm aware of. No, not that I'm aware of. I don't think that it would have an impact on that.
Mm-hmm. How do you promote good bacteria growth in bowels while having to do some of these things? So is there any recommendations in terms of diet or other things to kind of make sure you kind of have the right stuff there?
Yeah. So, recently, there's a group called the Paralyzed Veterans of America that kind of supports publishing the most recent evidence about spinal cord injury, and the bowel one was updated pretty recently within the last 1 to 2 years. And they comment on that in particular that we actually don't really have great information about what to do with probiotics or other medications for spinal cord injury. And so they shouldn't be automatically or routinely offered. In general, we actually don't know the right type or dose of probiotics, for example, to take to help improve gut flora for people who might be on antibiotics or have other reasons that their gut flora might change. So there's no evidence-driven information on this topic. What I would say is that there are probiotics out there that can be one way. The idea is that those help replenish the good bacteria in the gut. It's just that we don't have great guidance for what to suggest for that. Other things that can help include kind of fermented foods and yogurt that tend to have kind of some of the good bacteria in it. But similarly, for what we know about spinal cord injury, there's no, it's actually, not recommended to routinely suggest doing that because we don't know that it's going to be helpful or not.
We did in 2018, I was just checking, we did a forum with Dr. DiPaolo in our Center for Microbiome Sciences, and he spoke, and so that video is available online. It's called Probiotics, What Are They and Should I Take Them? And while he's not an expert in spinal cord injury, Dr. Reyes also followed and kind of talking about, again, like you said, there's not a lot of evidence, but just some of those kind of recommendations based on kind of what the current science is. I think we're still getting there.
Yeah.
Any recommendation on time before the bowel program to drink magnesium citrate?
Yeah, that tends to work kind of on the order of hours, maybe around 6 hours or so. So honestly, for some people, it only takes an hour or two to work, and for some people, it takes the full 6 hours to work. So that tends to, individuals have different responses to it, but a few hours before.
A similar question of, kind of changing over time. I feel like one of the things I hear from people is something causes a change in a bowel program.
Yeah.
And then, I guess any ideas or thoughts on how to reset, because what I hear is like, it sounds like sometimes people need to try a number of things, but, due to an illness or a hospitalization or some kind of change in function, that there may be like a change in kind of how the bowels are working. How do you do the reset?
A lot of times if we're thinking about a reset, we might take a picture, an x-ray to see how much stool is in there. Try to do a clean out with using mag citrate, for example, and to start on some of the basic medications, which might include Miralax and Senna, as people might be on when they first have a spinal cord injury, and then titrate from there. So we might kind of start with a clean slate and try to empty the bowels and see where we can go. One thing I would say is that if somebody has a really sudden change in their bowels, that could indicate a different problem is going on. So in the same way that if somebody has a pretty sudden change in their spasms or their spasticity, it's worth checking in, because it might mean that there's a different new problem with the spinal cord or the spine that's causing problems, and that we would address really differently than if we don't think any of those things are going on and are working on the bowels alone. So if it's something that really is different, then a lot of times we do look into it further, both into the spinal cord and the spine itself, as well as other medical things that can cause constipation or diarrhea. If we don't really find a clear reason, then work on kind of resetting in that way.
Can abdominal adhesions cause complications in a bowel program?
Abdominal adhesions can cause problems with constipation or stool impaction, or more seriously, obstruction. So it can impact how the bowels are moving. It's more important to make sure that people don't get constipation if they do have adhesions. So there is an interplay there. I wouldn't say that it has a direct impact in the day-to-day, as much as we know that the adhesions put them at risk of other complications, and we want to be aware of that.
Someone asked if it's common for men to have erections during a bowel program?
Oftentimes, kind of stimulation of various kinds to the body can cause an erection. I guess I don't know how common it is or not, but it certainly is something that may trigger a reflex erection.
Oh, here's somebody's asking about how much magnesium do we take if you're using that?
Yeah, so there's a few different forms of magnesium. And for some things that are not like spinal cord injury related, like heart conditions, sometimes people are supposed to take a specific dose of magnesium on a daily basis. In general, that's not needed, but the range of the most common magnesium medications is between 400 and 800 milligrams a day is usually the range of magnesium, but it differs a little bit depending on which medication it is. I would say that's the exception of magnesium citrate, which is in a different, the pills are in the 400 to 800 milligram range. The magnesium citrate is a liquid. That's a different range entirely.
Got it.
Yeah.
Do they do the same thing though?
They work in the same way.
Okay.
Mm-hmm. Yeah.
But kind of
they pull water into the intestines, which then loosens the stool and gives like a stimulus to move things along. So they tend to be, depending on the dose, the magnesium citrate is the strongest, kind of a strong propellant of moving things along.
Get things moving if you need
Yeah.
them to move.
Mm-hmm.
Excellent. All right. Well, I think that we are going to wrap up. Thank you again so much, Dr. Delaney. I very much appreciate you being with us. And have a good night, all.
Yeah. Thank you,
We're getting
everybody.
Lots of thank yous on chat as well.
Yeah. Thanks, everybody.